Over to you, Naba. We've got till about just before 4, if that's okay.
Yes, should be fine. Thanks, Sam. So yeah, I'm going to talk about metabolic screening for cardiomyopathy. I'm sorry I wasn't able to attend some of the earlier talks, which would have been really interesting, but I've just handed over the on-call and rushed here now. So I just caught the end of your talk, Grazia, and that was those cases were really interesting. And I didn't have time to ask now, but I am interested in that mitochondrial case and just whether there was ever any genetic diagnosis. Metabolic causes of cardiomyopathy are, I guess, not uncommon, and certainly a certain sort of small percentage of inherited metabolic disorders will be associated with cardiomyopathy. But when we think of cardiomyopathy and could it be metabolic, then certainly a decent proportion of cardiomyopathies presenting in children are resulting from IMD. And they're variable figures reported, so 5 to 10%, but maybe even as much as 22% or more in more recent studies that I've seen. And I guess in infancy and early childhood presentations, IMD may well be a more common cause of cardiomyopathy in those patients. We do see cardiac involvement in a range of IMDs, and I guess we contrast the ones where we see this as a presenting feature or a principal feature versus involvement at a sort of later stage. So I'm thinking, for example, with fatty acid oxidation disorders or with Pompe disease, where we might expect, or infantile Pompe disease, where we might expect cardiomyopathy to be presenting in infancy versus some of the other storage disorders where we may see cardiac involvement or cardiomyopathy presenting or becoming symptomatic later in childhood. Mitochondrial disorders are, as ever, extremely heterogeneous and can present at any age with multiple symptoms or even and multiple organ involvement. So it's very broad. Today we're thinking about the neonates, and most of the screening that we do is kind of targeted at cardiomyopathy in infancy. And I was thinking, well, which of the things actually do we commonly see really in the neonatal period? And probably it will be the big groups will be fatty acid oxidation disorders and carnitine cycle disorders, mitochondrial disorders, as we've mentioned, to some extent CDGs, which are disorders of glycosylation, which are considerably rarer, I guess. And infantile Pompe disease, the average age of onset is probably just outside the neonatal period, but it's definitely possible for them to present in the neonatal period. I'll show you a case and a couple of cases as well that highlights that. And those, I think, are the big groups that we should be aware of. So thinking, what are the clues and could it be metabolic? So there are some things to think about. So certainly if there's multi-system features and other organ involvement, then we have to think about, could it be metabolic? Could it be mitochondrial disorder, for example? Are there supporting biochemical features? And that might be from first-line investigations looking at, is there liver involvement? Is there CK? Is there lactic acidosis? Is there hyperammonemia? And acidosis, and second-line tests, which I'll go through as well. And there may be other clues, and I guess some of this is not necessarily relevant to the neonatal period, but is there, CNS involvement as well? Is there hypotonia? Is there other biochemical features such as hypoglycemia? Some of the other basic blood tests I've already mentioned, and dysmorphism might be a clue to a genetic or a metabolic disorder. Hernias, again, I think this is really looking at lysosomal storage disorders and MPS, which perhaps is more relevant later in life. And of course, there may be a family history. There may be consanguinity in the family that might be relevant. So I guess there are different processes that we think about that might be contributing to the development of cardiomyopathy in the context of metabolic disease. So we talked about a little bit about lysosome storage. So there may be complex molecules and GAGs being stored that affect heart muscle function, muscle fiber function, might be glycogen storage or disturbed autophagy, and this is what we see in Pompe disease. There may be other toxic metabolites that accumulate more acutely, such as in the organic acidureas that disturb cardiac function. And the other group, the main group, is there a failure of energy metabolism, and that could be, and that's what we see with mitochondrial disease and with fatty acid oxidation as well. There are perhaps some clues when we think when we're thinking about which metabolic diseases it might be. To some extent, the pattern of cardiomyopathy that we see might help us think about the differential within metabolic diseases, and extremely simplistically. So we are a simplistic bunch as a metabolic paediatricians. Storage we tend to see associated with hypertrophic cardiomyopathy. The intoxication I would generally associate with dilated. If there's energy failure, then we may see hypertrophy, and sometimes we see this non-compaction appearance as well. And actually, that is very classically associated with Barth syndrome, which is an X-linked syndrome with neutropenia and cardiomyopathy, but it can be seen in mitochondrial diseases. And actually, this is so non-compaction. I'm sure the cardiologist will be able to explain better than me, but this abnormal appearance of the cardiac muscle, which hasn't developed normally, and that normal process of compaction of cardiac muscle fibers hasn't happened. And we see that, as I said, in Barth and in mitochondrial etiology. So that might be a clue, although, as I said, mitochondrial disease is so heterogeneous, you can see any pattern really. So I've tried to divide up, and this is again very simplistic. This is the most predominant pattern that's reported in the major groups of IMDs that we see, and that's so it's not to say that they couldn't have different appearances. They certainly could, but these are perhaps the most predominant patterns. And so if we think about the big groups, fatty acid oxidation, generally speaking, is hypertrophic. Pompe maybe hypertrophic or maybe mixed. And we can see different patterns in different GSDs or different disorders of blood oscillation. But with the intoxication type disorders, and particularly with propionic acidemia, we tend to see a dilated picture. So I thought I would show a couple of cases. I think I have 3 cases to try and illustrate some of the major groups of IMDs that we see. And these are all cases that have presented in the last year, I think. So the first one is a 34-weeker who's the second child of consanguineous parents, and she was born in not terrible condition, but did need to be transferred to the neonatal unit for CPAP and had ongoing support. And then reasonably early on day 3, picked up hyperlactatemia. She was treated for sepsis and query NEC, but the lactatemia persisted, and we were contacted and arranged some investigations. And she had a respiratory and cardiovascular deterioration about 2 weeks in. And actually, the first echo was done at that time, and there was a very dilated left ventricle, severely impaired by ventricular systolic function. So that led to or metabolic investigations being done, but in this particular case, it was the acyl carnitine profile that proved the most helpful. And just to show that it's not always the case that the pattern that we expect is what you see. This very much looked like a fatty acid oxidation disorder. So there was a long chain fatty acid, long chain acyl carnitines that accumulated, suggestive of a long chain hydroxyacyl carnitine, acyl CoA dehydrogenase deficiency, or MTP, or mitochondrial trifunctional protein deficiency. So those two things are both long chain fatty acid oxidation defects. There's 3 enzymes that work together in a complex at that stage of fatty acid beta oxidation, and that's the mitochondrial trifunctional protein. There is a mutation in HADHA, which is associated with the isolated deficiency. Sorry, is that isolated deficiency of the activity of LCHAD. But otherwise, we see mutations that affect the whole trifunctional protein complex. And this patient, we found actually a null mutation causing a severe defect in HADHA. So this is affecting the whole trifunctional protein complex, and is really a very severe condition. Can be treated. So the treatment is really with a restriction in low long chain triglycerides in the diet, so a low LCT or minimal LCT diet and lots of MCT. And she did initially very well on this, and actually her cardiac function really improved, and she was stepped down to the ward and eventually discharged, gaining weight, and did reasonably well, but unfortunately came in with an intercurrent illness only a few months later and decompensated very severely, and was admitted to our PICU and died, unfortunately. So this is really a very severe condition. Fatty acid oxidation disorders in general are so there's a reliance on fatty acid oxidation for energy production for the myocardium, and there's a change really in the transition from fetal to neonatal in terms of the energy metabolism. So there's in fetal life, the energy production in myocardial ATP is predominantly from glycolysis and lactic oxidation, and then rapidly there's a change to relying more on fatty acid oxidation. So that at that point is when we really see severe fatty acid oxidation defects presenting. And really, in the neonatal period, when it comes to cardiomyopathy, we're looking at some of the carnitine cycle defects. So carnitine is a molecule that's required to shuttle long chain fatty acids into the mitochondria to be beta oxidized. And of those, really in the neonatal period, it's probably the CPT2 deficiency that we see. CPT1 generally we don't see with cardiomyopathy, and the carnitine transporter defect certainly can, perhaps a little bit in slightly older patients. And then you have the spiral of beta oxidation of long chain fats, and it's really the very long chain and the long chain defects that we see associated with cardiomyopathy, and not really MCAP deficiency, which is more of a can cause arrhythmias, but not so much cardiomyopathy, and is screened for in newborn screening now. So those are the common defects that we see, and the clues really from the biochemical point of view will be lactic acidosis with often liver dysfunction. So you may see elevated transaminases and may see a raised CK as well. And the screening for this would be the carnitine and the acyl carnitine profile. Second case was again a baby who was born to consanguineous parents. There was a bit of a family history here of a sister that died at nearly 2 weeks with prematurity and high drops. So they had a fetal echo at 20 weeks, which was normal, with reduced LICA volume at 34 weeks. So they were born by semi-elective section at 34 plus 6 weeks because of reduced fetal movements. I think originally a section was planned at 36 weeks. And born in relatively good condition, admitted to the neonatal unit because of respiratory distress and low SATs, and was found to have anemia, but also persistent lactic acidosis. And so there was cardiomegaly on a chest X-ray, and there was bilateral ventricular hypertrophy, atrial and ventricular hypertrophy on the echo, with poor function. And this baby was dysmorphic. I don't think I saw this baby myself, so I don't remember exactly what the features were. But clearly there was other organ involvement. So there was abnormalities on the cranial ultrasound, and we did an MRI of the brain as well, which showed bilateral cortical diffusion restriction, a smaller for age cerebellum, and especially the cerebellar vermis. And when we did the MRS, there was a small peak of lactate at the basal ganglia. So we became quite suspicious of mitochondrial disease. The other thing from the IMD point of view that we see that might be associated with the cerebellar vermis hyperplasia is the congenital disorders of plaque oscillation, which we didn't think about here, but I think we mostly focused on could this be a mitochondrial etiology? And so when we did the cardiomyopathy screen, we also, when we did the investigations in terms of treatment, we also started riboflavin. And this is because ACAD9, which causes a complex 1 deficiency, can be responsive to riboflavin. I don't think we necessarily felt very suspicious that it was that defect, but it was possibly one of the only possible treatments for a mitochondrial cardiomyopathy. So we started it empirically. Unfortunately, things progressed, and this baby got worse, and biventricular hypertrophy worsened and function worsened, and unfortunately, this baby continued to deteriorate. The metabolic screening, essentially, the acyl carnitine profile was not specific. We did see a raised C4 acyl carnitine, which is very non-specific, but we do sometimes see that in mitochondrial disorders. And in the urine organic acids, we saw lots of lactate, but we didn't really see anything else very specific. But if you can, as you see in the graph, the trend of the lactates shows a persistent hyperlactatemia, and this is, despite inotropic support and good perfusion with that, continues to persist, and so we felt that it was a primary lactic acidosis. And actually, in this case, the diagnosis we achieved from the R14 rapid exome, where we sent to Exeter, and we found homozygous variants in this gene, which encodes the mitochondrial phosphate carrier. And interestingly, Grazia, you presented a case where we did a muscle biopsy. There was a muscle biopsy and there was an abnormal muscle biopsy, and that suggested mitochondrial disorder. Interestingly, here we did a muscle biopsy and it was completely normal. And actually, there's no deficiency of the activity of any of the mitochondrial respiratory chain complexes in this case. It's more of a substrate problem. There's a deficiency in the phosphate transporter, which transports an organic phosphate across the mitochondrial membranes, allowing it to be incorporated into ATP. And so we don't actually see any defect in the mitochondrial respiratory chain complexes, but it is essentially a mitochondrial disorder. This baby, as I said, continued to deteriorate, and after MDT discussions with the family, we pursued full supportive palliative management, and they died at 27 days. And so mitochondrial disorders, as I've said, it's the most common defects that we see that are associated with cardiomyopathy can be involving complex 1 or complex 4 or combined defects, but it can be really many of them. And the cardiac phenotype can be very variable, as I said. So there may be clues because there's other organ involvement. So here there was clearly CNS involvement as well. And it's worth thinking about, is there renal involvement? Is there tubulopathy? Is there liver disease? Are there cataracts? And the biochemical clues, it's not easy to tease out. Lactic acidosis is extremely common, or hyperlactatemia is extremely common. But if it is really persistent despite really good perfusion, then that's a clue. And sometimes not just the lactate, but when we look at the amino acids, that can be a clue, because if there's a persistently elevated lactate, we might see elevated alanine or elevated proline on the amino acids, and that might give us a bit more of a context to say that we think that that's persistently elevated lactate. The urine organic acids can provide some non-specific clues. So sometimes we see Krebs cycle metabolites, sometimes we see 3-methylgluconic acid, but again, it's really non-specific, and the diagnosis is then not always straightforward. There's generally no specific treatment, but we might recommend, as I said, riboflavin. Some of the other cofactors and vitamins we use, very variable practice, and there's not really good evidence for any of them. We might suggest things like thiamine in case we think there's PDH deficiency, or biotin in case we think there's biotinidase deficiency. But from the point of view of the cardiac involvement, it's probably the riboflavin that we would think about most commonly. The way that we diagnose mitochondrial disorders is changing, I guess, and this is the kind of classical way that we used to do it before we had increasing access to genetic testing. So if there was a characteristic clinical syndrome, then we would, and we recognised that we would test for the common mutation. But if not, which was probably more often the case, then we would do actually functional testing and look at muscle biopsies and skin biopsies, and do immunohistochemistry, and electron microscopy, and respiratory chain complex analysis. And then based on that, look at doing molecular genetics. But these days, we increasingly are taking a genetics first approach. I mean, again, if we recognise the syndrome, we will go straight to looking for that common mutation or that gene. If not, then we tend to now do a bit more of a wider sort of genetic screen, and that could be looking at a large mitochondrial DNA sequencing, or a large nuclear panel, which we tend to send to Newcastle in practice, but increasingly, as I showed in this case, using the rapid exome service. That doesn't mean that answers the question, because we may well not get an answer, or we may get an answer that's difficult to interpret because of variants of uncertain significance, and then we go on to look again functionally, and we may still need to do muscle biopsies and so on. And indeed, it's still probably useful in a patient that's sick and deteriorating, and we anticipate to get worse, to try and get a muscle and skin biopsies pre-mortem, to try and help us interpret any genetic results that we do get back. And a final case. So this is a child of non-consanguineous parents, this time born at 38 weeks, no particular family history of note, and soon after delivery developed respiratory distress requiring oxygen, and did have an elevated lactate and a metabolic acidosis associated with that. Cardiomegaly again on the chest X-ray, and echo this was at the local hospital. There was biventricular hypertrophy, and so they were started on carnitine supplementation in case there was a carnitine transporter defect, and then transferred to a tertiary hospital for us to work up. And we had a repeat echo that confirmed biventricular hypertrophy, and an ECG that showed high voltages and a shortened PR interval, which Grazia already mentioned, as one of the features that we might see in Pompe disease. And we confirmed this on on enzymes, so that alpha glucosidase enzyme was urgently confirmed a deficiency, and we started treatment fairly early on. So this was treatment with enzyme replacement therapy, and she's doing pretty well at 3 months of age. Still has a little bit of hypertrophy, but much improved function, tolerating some oral feeds, but was mostly NG fed, but generally doing pretty well. And this is a really important one to pick up because there is a treatment, and certainly the earlier you start it, the better the outcome. So Pompe disease is classed as both within the glycogen storage disorders, but also in the lysosomal disorders, because it's the lysosomal enzyme breaking down glycogen in the lysosomes that's deficient. And there's infantile onset and later onset, and this kind of cardiac picture obviously more common in the infantile onset. It's worth knowing, the supportive diagnostic test to screen for them. So there may be these ECG features that I mentioned. We can look at whether they're vacuolated lymphocytes. We may see raised CK, we may see abnormal LFTs, but the key test is going to be the alpha glucosidase enzyme test, which can be done on a blood spot, but also on an EDTA sample in leukocytes. And often the labs can give you a confirmed diagnosis quicker on the leukocyte sample. So if you're really suspicious, I think that's what I'd send, but as part of a screen, then the blood spots. And the outcome is much better the earlier you start, but also depends on whether the patient has a genotype that means that they produce, whether or not they produce any residual protein or not. Because if they don't, then they're much greater risk of developing antibodies to the enzyme, which is associated with a much worse outcome. But again, it's a key one to pick up because there is a treatment. So I'm aware that time is coming to an end. So I've just put up the slide, the slide kind of summarising the investigations that we often recommend from the metabolic point of view in cardiomyopathy, and just separated based on which kind of which groups of IMDs we're targeting. So as I said, with fatty acid oxidation defects, there'll be some. There may be hypoketotic hypoglycemia, so we do the glucose and the ketones. CK and LFTs will be useful. Urine organics and the acylcarnitines are going to be the most important biochemical test to confirm diagnosis. For Barth syndrome, as I said, one of the really key diagnostic metabolites is the 3-methylglutaconic acid in the urine. And as a kind of initial clue, but if we want to make the diagnosis, we need to send the cardiolipin profile. For mitochondrial disorders, again, making the diagnosis is complicated, but it's useful to know, is there persistent lactate? Are there other organs involved? And is there evidence of tubulopathy? With organic acidemias, again, it's ammonia and a blood gas. So is there acidosis, hyperammonemia, and is there kind of an intoxicating picture with encephalopathy? But we make the diagnosis on organic acids and acylcarnitines and amino acids. And lysosomal disorders, I think, mostly are not going to present in the neonatal period, except for probably Pompe. So it's the blood spot and the EDTA sample that are most important. And CDGs I haven't really talked about because they are really quite rare. But what I will say is that you may have dysmorphism and multisystem involvement, and the screening test is the transferrin isoelectric focusing. But just to be careful, because that test is a little bit unreliable in the neonatal period because of maternal transferrin. So if you really are suspicious from that point of view, we'll probably ask you to repeat it after around 3 months. So those are the metabolic investigations. So I guess in summary, metabolic causes are not uncommon. The things that might give you a clue would be, is there multi-system involvement? Are there any initial biochemical clues? And then thinking about what pattern of cardiomyopathy you're seeing. But still, initially, we tend to still do a broad biochemical screen, but as I've illustrated, there's increasingly a role for genomics and rapid exome. So that's it.
Thanks, Nabha. Thank you for that. I think everybody's coming back from the breakout session.